sure it's recording.
Oh, yeah.
We'll just give it one more minute. It looks like people are still joining. But now I think that might be everybody. We've got 14. Okay, we'll get started. So hi everyone, welcome to the Parkinson's and Swallowing webinar with Jenny Pachet. My name is Emma Tornero and I'm a client service coordinator for the Parkinson Association in Calgary, and I'll be moderating the webinar. If you have questions during the webinar, there is a chat box and I'll get it started for everyone, so then you can enter your questions there and we will answer them at the end. And then if you have more questions at the end, feel free to add them there as well. Just as a disclaimer, the webinar will be recorded. All the information provided in the videos by the Parkinson Association and our featured speaker are furnished strictly for educational and entertainment purposes only. The service is not intended to be diagnostic, prescriptive, or replace the relationship, advice, or care of your physician. And general questions about symptoms or medication will be fielded. So our speaker today, as I mentioned, is Jenny. She's a speech-language pathologist and has been for 20 years. She's worked with adults in acute care, neuro rehabilitation, and long-term rehabilitation. Her areas of expertise include stroke, brain injury, and neurodegenerative diseases such as Parkinson's disease. Currently, she's in private practice seeing clients who have issues with communication, speech and language, cognitive communication, and swallowing. So I'll hand it over to you now, Jenny. Thanks.
Awesome. Thanks, Emma. Thanks so much for joining me this afternoon. As Emma said, I'm a speech-language pathologist and I'm here in Calgary, Alberta. And I am going to share my screen with you to show you presentation. So here we go. So this session is about swallowing and Parkinson's disease. So if you have any questions sort of along the way, you can kind of put them in the chat. I don't know if I'll see them right away, but I certainly will be able to answer them all, especially at the end. So an overview of the presentation today, I'm going to give you a little bit of an introduction about who I am, as well as the main reason you're all here is to hear about the swallowing issues in Parkinson's disease. Then I'll talk a little bit about when it's time to see a speech-language pathologist, a couple of internet resources for you, and then we'll have time for some questions. So I have a Master's of Science in Speech-Language Pathology and Audiology from California State University, East Bay. I've worked in Ponoka at the Halvard Johnson Centennial Center for Brain Injury. I've also worked at the Foothills Medical Center in rehabilitation and in acute care, but mainly with brain injury, stroke, and spinal cord populations. And I've worked casual hours at the Dr. Banning Center for several years as well. Right now I'm in private practice, and like Emma said, I see clients with neurological issues affecting speech, language, and swallowing. So I find that when talking about issues to do with swallowing, it's important to look at the anatomy and physiology of what is normal so that we can also see what abnormal or disordered swallowing would look like. So to start, I want to talk to you about there's 4 stages to swallowing. We have the oral stage, which is where we start chewing the food, and that's the very first stage. It's the oral prep stage. Then we have the oral stage where the food is in the mouth and it's kind of being rolled around into what we call a bolus. So it's kind of like a ball of food that's being prepared. Then what happens is that ball of food sort of gets pushed back into the throat, and we call that the pharyngeal stage. And at the end, we have the esophageal stage where it goes into your food tube down into your stomach. So I'm going to show you a little bit about what the anatomy and physiology looks like. So this is a side view of a person. So we have your lips, your teeth, your jaw, your tongue. So the oral prep stage that I mentioned, that's where you're chewing the food with your teeth. Your lips hold the food into your mouth. And that's the prepping, that's the kind of the grinding, the chewing to try and break down the food into smaller bits. Then we have the oral stage where that food moves from that front of the mouth into the main part of the mouth, and the tongue starts to kind of roll it around to try and put it all together in a ball. Then we have sort of that finger-like projection called an epiglottis. And that's part of the anatomy that's really important for the pharyngeal stage. If we look at the larynx, where it says larynx, there's kind of these little lines right above that arrow. That is your vocal cords. So they sit right behind, for men, we kind of call it the Adam's apple. It's called your, it's kind of like a bone that sits there that protects those vocal cords. And those vocal cords, their main job is, we talk about using them for speech, but their main job is actually to protect your lungs from food or fluid going into the lungs. So where it says larynx, that is your trachea. That is your windpipe. And it's made up of cartilage that helps keep that windpipe open. If we had a windpipe that kept collapsing, we wouldn't be able to breathe very well. So that windpipe is open all of the time. So it's quite a big tube. If you look over to the right, you'll see the esophagus. There's an arrow, and it's pointing to a much more narrow tube. That is more muscular, and it sort of moves around the food as it's going down that tube. I kind of liken it to a snake. So, you know, when a snake bites into a mouse or something, you can see the mouse kind of going down the snake's body. That's sort of the same with the esophagus. It kind of molds itself around what's going down. So it's sort of, it doesn't stay open like the trachea does. So what happens is when we swallow, your larynx actually, that bone right in front tends to lift up and forward. And when it does that, that finger-like structure, that epiglottis, tips down to cover the airway where it says the larynx opening into the pharynx. That covers it and protects it from food or fluid going the wrong way. We've all had that time where we've had something to drink and we start coughing and coughing and coughing and say, it went the wrong way. That's the reflex of when something touches those vocal cords. It's a reflex to try and cough it back out again to clear that airway, to prevent any food or fluid from going down further into the lungs, causing a potential infection. So that epiglottis tips over and all the food sort of is supposed to kind of go down the way to the esophagus. If we look up above the tongue and it says palate and oral cavity, there's another little structure that hangs down at the back, and we talk about it, it's that little punching bag at the back of your throat, your uvula, but it's attached to the soft palate and it sort of is curved like this. So also when we swallow, that tends to close off our nasal cavity so that food or fluid doesn't go up and out from the nose. And occasionally, I'm sure people have had that experience too, where you had a sip of some kind of liquid in your mouth and someone makes you laugh and you start to laugh and it comes out your nose. That's because that soft palate didn't have time to sort of close in time because of the timing of what happened with the laughing. So that's sort of what a normal swallow would look like. And I want to show you, a video of what a normal swallow looks like. Now that you've sort of seen that anatomy, I want you to see the physiology at work. So I'm just going to share another screen with you. And, oops, where am I going here? I had it and I lost it. So, try that again. I don't know why it's not letting me do this. Sorry, everyone. I'm trying to find where I was. Sorry, Emma. Huh. I'm not sure why it's not coming up.
No, that's okay. Take your time.
I'm not sure. What are you actually seeing, Emma?
We can see a view of all of the bones, and then on the side it says normal swallow lateral view. And it looks like a video that could be played.
Okay, so that is what I want, but I'm not seeing it on mine. So I'm just going to stop it for one moment. And there we go. Hi, I'm back again. Let me see. All right, this will work. Okay, so if you look, we've got the same sort of structures that are happening. And I'm gonna play you a short video so you can see what it would look like if you had some food in your mouth and how it would go and how it would look for a normal swallow. I've put it on a slower speed so you'll be able to see what's actually happening. But usually a normal swallow happens very quickly. You chew, you put it in your mouth, you swallow, and it's gone. But I've slowed it down slightly. So I'm gonna show you what it looks like. So there it is. It's sort of in the oral cavity. Gone now. You can see that the epiglottis tipped down and then it went all into the esophagus. So I'm going to play it again for you so you can see it again. You can sort of see the white at the bottom is the trachea that's open. And you can see how small the esophagus is to the side just behind it and how narrow that space is. So have a look again. So that's what a slowed down version of a normal swallow would look like. But like I say, this is kind of what it should actually look like in real time. Super quick. I'll let you see it one more time. And you can see that there's no white left anywhere. Everything is clean, it's clear, there's nothing left in the throat, on the tongue, anywhere. There's no white residue remaining behind. Okay. Okay, so now we want to talk about what would a disordered swallow look like. So swallowing issues are called dysphagia, and dysphagia is sort of, it just encompasses that you can have difficulty swallowing at any one of those 4 stages that can occur. It may be at one stage, maybe right at the beginning with the chewing, or it may only be the stage at the level of the esophagus, or it may be at all the stages. So issues for swallowing can occur at any time during the course of Parkinson's disease. Our biggest concerns are what we call aspiration, which is where food or fluid has gone past the level of those vocal cords that I showed you and has gone now into the lungs. The other issue of concern is what we call obstruction, which is what choking actually is. So obstruction is where no sound can come out. That means something is blocking the airway. And that may be where someone does the Heimlich maneuver to try and get whatever is blocking the airway out. So that's obstruction. When people are coughing, that likely means something has touched the level of the vocal cords, and we call that penetration. And they might be coughing because there's something sitting there and they're trying to clear it. Coughing is a good thing. It means they can still breathe. It means that they're trying to clear the material that's sitting there. Oftentimes people try and pat someone on the back to say, it's okay, just, you know, trying to get them to stop coughing. That's actually not a great thing, because sometimes it causes people to go and breathe in really strongly, which if there's any material sitting on those vocal cords, it sucks into their lungs instead. A lot of people say put your hands in the air when someone is coughing or choking, and I don't know how that actually helps. I think it's an old wives' tale, but it doesn't actually, physiologically, it shouldn't prevent someone from still trying to cough that material out. The best thing you can do is to encourage someone to keep coughing, because as long as they're coughing, they're trying to get out what's sitting there. So coughing is a good thing. It means they're able to breathe. Obstruction is where you have to try and get that out. So that's where, like I mentioned, the Heimlich maneuver or something would be important to do. Okay. So swallowing issues may not be noticed by someone who's got Parkinson's disease. Actually, sorry. Because sometimes we don't notice these things because they happen sort of gradually. But there may be things like weight loss that's happening, dehydration may be happening, even a pneumonia or an upper respiratory infection that keeps reoccurring. So an assessment would include a comprehensive history of what's going on. How long has the person been losing weight for? How often have they had a pneumonia? Those types of things. There may be something called a bedside evaluation of the swallow. And this is where a speech pathologist might watch you actually eat your meal and listening and observing to see what's actually happening when you eat. Another way that we can look at swallowing issues is a radiographic examination, like a modified barium swallow, which we call an MBS. Or there's also a fiber optic endoscope kind of thing that we use. We call it FEES. And it's where they can put a camera up through your nose and look down while you're trying to eat, so we can see what's going on when that happens. So features of dysphagia in Parkinson's disease, if they're happening at the oral stage, this would be where there's difficulty, maybe swallowing pills can be the earliest symptom, that they're having that difficulty of trying to get pills down. Sometimes what we do in these kind of cases is, if it's not a time release pill, it can be crushed up and put in something like a yogurt or a pudding or something like that to make it easier to swallow possibly. But if it is a time release one, we can't really break it up at all, but it may help to be put in something else as well, like yogurt, to try and swallow it down. At this oral stage, a lot of the dysfunction results largely from rigidity of the tongue and jaw. If the tongue is not able to move very well, it has a hard time rolling the food around to get it into a ball and to push it back further in the throat. So it may take longer to chew and move that food around in the mouth. And then, like I say, difficulty getting it together into that bolus to be ready to be swallowed. One of the hallmark features of Parkinson's disease is sort of a repetitive tongue pumping motion that makes it difficult to start a swallow. It's that feeling of, I'm trying to swallow, I just can't quite swallow. So for this, it's sort of one where it kind of actually helps diagnose Parkinson's disease sometimes too. We did have a patient in acute care who had come in for some other reason, to one of the units, but was having difficulty swallowing. And when speech pathology came in, we decided to do a modified barium swallow to look, and you could see this pumping motion happening. And we had asked if he had ever been assessed for Parkinson's disease, and he hadn't. And so this was the first symptom that he actually had, that we were able to then refer him to movement disorders, to the movement disorders clinic, to actually be further assessed, because we had noticed this type of motion. Swallowing saliva is normally very automatic, but you can begin to swallow less in Parkinson's disease, and this can cause some drooling. In the pharyngeal stage, we can have difficulty starting that swallow reflex, that feeling of needing to swallow several times before feeling the food actually go down. There can be a sort of a reduced force of contraction in the throat, where so excessive residue can sort of line the throat part. I think what I want to try and do here is I'm going to try and show you the actual what penetration and aspiration would look like in on that video, because you've seen the video where it's the normal swallow. I want to show you now, because this sort of is the pharyngeal stage, what it would look like disordered. So bringing it back up. Sorry, guys. I'm just going to try to get back into that screen again. Here we go. Thanks for your patience, everyone. Okay, I'm going to try going in a different way. Sorry about this. Why is technology so challenging? I'll tell you.
We had good luck last time and it worked, so.
I know, we'll see if we can get it to do it again. You know what? It's not wanting to right now. So I'm going to continue on, and I'll try again in a minute. But I would like you guys to see that video. So even if we have to go all the way to the end, I will figure this out. So that reduced force of contractions, the back wall of the throat, and the pressure from above to try and get those contractions to force things to go into your esophagus. If there's not enough strength for that, it can sort of leave residue in certain little pockets and on the edge of, and on the coating of the throat. So that buildup of residue can cause too much residue to build up after several swallows, and then that can fall into the open airway, either before the next swallow or after one of the swallows, just because there's too much buildup and it falls over into the open airway because there's not that protection of that epiglottis covering the airway. If there's too much muscle rigidity, the larynx isn't able to lift as high to pull forward. And again, that epiglottis can't tip, and the vocal cords may not come closely enough together to necessarily protect the airway if there's some weakness at the level of the vocal cords. This can create that increased risk of aspiration, and aspiration being where food or fluid has gone between the vocal cords into the airway. Like I said, if it hits the vocal cords, we call that penetration. If it goes down below, it's called aspiration. So it may have impaired pharyngeal and esophageal contractions at the pharyngeal stage, and that may make it difficult to get the food down into the esophagus itself, which would then put it in the stomach. So in the esophageal phase, it's the transit into the esophagus that continues to be a little bit slow. You're not seeing the material go where it needs to at any quick rate. We call this decreased peristalsis. That's that movement of that muscle trying to move the food where it needs to go. In this case, it's not uncommon to have complaints of heartburn or regurgitation, where it feels like something's coming back up again. And there may be reflux as well, or GERD. You may have heard of the term GERD, which is gastroesophageal reflux disease. And that can sometimes occur if there's issues happening at the esophageal phase. So here I have video, so I'm gonna try one more time to see if I can pull this one up and see how it goes. Okay. We will see if I've got it right this time. There, I have actually got it right this time. All right. So, okay. So here we have, this is going to be an example, again, I've slowed it down, of what penetration and aspiration can look like. So again, if you look at the picture, you'll kind of see where the mouth is. You'll see kind of that finger-like structure, the epiglottis sitting there like curved up. You'll see the trachea, which is all the white cartilage going down into the throat. You'll see the very thin esophagus from the side. I want you to pay attention and look at where white remains after the swallow happens, and we call that residue. So have a look and see what it looks like. So
Jenny, I'm not sure if it's happening for everyone else, but my screen is still just showing the PowerPoint.
Oh, okay, that's weird. Oh, it says my screen sharing is paused for some. Okay, let me see why it would have paused. Okay, weird. Let's try it again. How's that?
There we go.
Do you see
Perfect.
it now?
Yep.
Okay, sorry about that, everyone. Thanks for letting me know, Emma. Okay, I'll tell you that again. So it's going to be, there's the mouth. You can see the mouth. You can see sort of that finger-like structure just above the trachea. You can see how narrow the esophagus is. And again, I want you to kind of look to see where there's white remaining after the swallow occurs. So I've slowed it down, sort of, it's in the mouth, but you can see there's not a lot of movement. It sort of has spilled over. Some's going to the esophagus. Some of it is, now it's spilled over into the trachea. The epiglottis didn't really do its job, and now the person's coughing because it's reached the level of the vocal cords. So if you look, you can see there's a lot of residue all along the tongue, to the tongue base, into a little pocket above the epiglottis called your vallecula. And it's because there's just not enough air pressure to kind of force, and not enough contractions to try and get the fluid where it needs to go. I'm going to show you it again so you can see, but there's not a lot of movement. The larynx isn't lifting up high enough to let that epiglottis totally cover the airway. And that's when penetration happens, and the aspiration is likely because it's gone below the vocal cords. I'm going to show it to you in regular time as well, so you can see what it looks like in regular time. And that was the cough at the end there. So okay. So that is kind of the difference. You can sort of see how fast a normal swallow is and how there's nothing left behind, and how depending on what's going on with the person, they may have that kind of residue, they may have that penetration aspiration if everything's not functioning exactly how it's supposed to. So signs and symptoms of swallowing issues in Parkinson's disease. Things that you might want to be aware of is if you're choking or coughing when you eat or drink, losing weight, notice some drooling happening, perhaps meal times take longer than they used to, no longer enjoy eating because it is so much effort, some difficulty chewing food. You have to try several times to start a swallow and food seems to stick in the throat, or you have a history of pneumonia or upper respiratory infections. So how are swallowing issues in people with Parkinson's disease treated? Now, our swallowing issues are usually treated based on the type of severity, and they can be minimal, mild, moderate, or severe. And treatment can be compensatory or rehabilitative in nature. So the difference between that is compensatory is we put things in place to make eating safer, whereas rehabilitative would be we actually do things to try and strengthen the muscles to improve your ability to swallow, to make your swallow stronger and better. So I'm going to talk about some of the compensatory things first that can be done. Some of it is just things like posture, sitting upright at a table as opposed to, say, lying in a chair or eating in bed or something like that. So sitting upright, sometimes using different types of strategies like tucking your chin may help, but it doesn't help everybody. For some people, it makes things worse. So a chin tuck should only be done if it's found helpful when you were actually, say, under a modified barium swallow, and they could see that, yes, when that person chin tucks, it makes it better. Things that we would do, say, if someone had a stroke and they had weakness on one side, we would actually suggest maybe turning their head to the weak side so that it forces the food or fluid to go down the stronger side. So that would be a postural type of change that we might do to help improve somebody's swallow and make it more safe. Sometimes increasing the sensory input for the food, so increasing the seasoning, cold foods, sour foods, carbonated beverages, those may help trigger a faster swallow response because it sort of wakes up all of the senses for when you're eating. Some more things that you might do is, say, feeding modifications. If there's a tremor, there may be a utensil that is used, a weighted utensil that stops that even if the tremor is happening, the spoon itself stays stable. It may be things like suggesting you alternate liquids and solids, that if you have too many solids, it builds up, so you need to be able to clear it with some of the liquid. It may be things like allowing you longer time to eat, smaller amounts more frequently to help with nutritional input. These are all things that can be suggested depending on your specific situation. Diet modifications would include changing the texture or of your food to make sure that you are able to handle that type of food more easily. So maybe softer foods, perhaps salads and crunchy vegetables are going to be too difficult for chewing, and if you're having difficulty at the chewing stage, but maybe steaming your vegetables and making them softer would make it easier for the chew. Less crumbly, hard, and sticky foods. Those ones tend to be tough. dry crackers, nuts, toffee, peanut butter. Some of those things can be very tough to sort of manage in the mouth if the oral stage is compromised, for the tongue to be able to handle those foods and to turn them into a bolus to be able to transport them. One thing that we found is a lot of people, like with a hard-boiled egg, if you love eggs, great, but perhaps try having them scrambled or softer and cut up, or a soft-boiled egg. We find that when it's a hard-boiled egg, that the yolk can be really kind of pasty and sticky, sort of like peanut butter, and that can make it very hard to manage in the mouth. So it's sort of looking at the types of food you're eating and determining what is easy to eat and what's not as easy to eat. Also, things like rice may be more difficult to do because it's got those little tiny pieces in them. I have on there no mixed consistencies. So what is a mixed consistency? A mixed consistency is where you have a solid and a fluid together. So cereal and milk, minestrone soup, things like that, fruit cocktail where you have solids swimming in some type of liquid. Why those are challenging is because when you take a mouthful of both of those things at the same time, you're trying to chew the solid pieces while trying to manage the fluid. And what often happens is while you're trying to chew those solid pieces, the fluid is running away into your pharynx before you're ready to trigger that swallow. So it can be a little harder to manage. But a proper assessment will help to determine what's going to work for each person, because what works for one person may not work for somebody else. And that's why once you've had an assessment, these suggestions can be made to make it easier and safer for you to be eating. For some, it may be airway protection maneuvers, where we give suggestions that when you're eating, you make sure you give a really hard swallow. So you're squeezing everything together to get that swallow. Sometimes it may be like a double swallow, where for every mouthful that you take, for every bite you have, you swallow twice before putting anything further into your mouth. Things like supervised eating and being well rested can be important. You don't want to eat when you're at your most tired of the day. Have somebody there so that if you are prone to obstruction, that somebody is there to make sure that you're safe. Another issue is med changes or the timing of medications. So Cinnamate should be 30 to 60 minutes before eating, because the amino acids in meats and dairy can impact the absorption of the medication. So it's really important to sort of have that timing of your meds with what you're actually eating. Another very important thing is oral health and hygiene. The research has shown that people with Parkinson's disease tend to have greater oral health problems than the general population and increased risk of periodontal disease due to their tremor, the hypokinesia, and rigidity that interfere with oral care. So tremor impacting brushing the teeth, or that really hyperkinesia means decreased movement. So that stiffening of the movement may not get as good oral brushing as they're used to. But this is really important to have very good oral care, because our mouth has so much bacteria in it that there's some people who actually can aspirate their own saliva. So we want to make sure that everything is clean in the mouth, because if we aspirate even saliva with some bacteria in it, that may also cause some type of respiratory infection. So oral care is paramount for everyone, especially those with Parkinson's disease. When it comes to saliva and drooling, saliva production is actually reduced due to levodopa, but because people with Parkinson's have decreased spontaneous swallow and decreased oral motor control, so sometimes that lip closure, the lips don't come together as tight, sometimes by being kind of stooped over, and a little bit of decreased attention to drooling, that can frequently occur. So it's really kind of to notice some of that. And I know people are like, drooling, I have dry mouth, my medication causes dry mouth. So I'll talk about that in a moment as well. So for management of drooling, there are certain drugs that may help slow down the production of the saliva. For some people, they can get Botox injections right into specific salivary glands, which can help decrease the amount of saliva produced. For some, radiation and surgical treatments could happen. This one is a little bit tough because those, when you've got people who've got head and neck cancer and they've had radiation done to their head and neck, it kind of decreases it so much that they don't produce enough saliva. So I don't highly recommend the irradiation one unless it's severe amount of drooling. That should actually be another point, the increased awareness of swallowing. So for some people, just being aware of needing to swallow, it's sort of that decreased attention. Instead of swallowing every once in a while, it takes a long time before people swallow. There is an app. There used to be one called Swallow Prompt, and you can set a timer on it to kind of vibrate on your phone so that every, say, 4 minutes, it vibrates. And you're like, oh, that's the cue for me to swallow. So there are sort of those helpful things too that just remind you to swallow again. For some, it's that sensory stimulation. Those EOS kind of eggs that you can get at Walmart or wherever, where it's sort of a flavored lip balm that can provide a sensory cue to keep lips closed. Spritzing your mouth with a mixture of lemon juice and water can sometimes trigger the swallow too. It's sort of that sour taste that we need to sort of trigger that sensory input. And now I talk about that dry mouth. If you have xerostomia instead, what are some things that you can do? Some people kind of sip water throughout the day. It's been suggested to have a throat lozenge of some sort, Tic Tac, a lifesaver, those types of things, but you have to be careful to maybe not have too much sugar, because having that all day long might not be great for you either. There are some products in the market at the drugstores, such as liquids or lozenges that might help for dry mouth. I think Biotene makes several products like that. And then, you don't have the handout on this, but if you want the handout on xerostomia, I can certainly forward it to Emma, and she can get it to you. One thing that's been researched is gum chewing, and some of you may have heard of this, and this comes out of South and colleagues from 2010. Where the swallowing frequency increases and swallowing latency decreases. So that latency means that kind of delay, that slowing down, that decreases during gum chewing. So if you're chewing your gum, you're creating a lot of saliva, you tend to swallow more often. The problem is that when you stop chewing the gum, it reverts back to not swallowing as often. But this may be a cost-effective way to decrease the impact of your salivary flow. They suggest that you could chew several times a day, and it's helpful before and after a meal to remind you to swallow. So maybe chew the gum 15 minutes before you're going to have your meal, and then when you have your meal, you continue to be able to swallow more easily. Or when you're done your meal, have some of the gum to try and keep swallowing, to try and clear anything that may still be in your pharynx. When it comes to medication, levodopa has not been shown to improve swallowing, but some of the motor events related to eating and swallowing may be enhanced by the medication. So it's not expressly for swallowing, but if you're alert and everything's working quite well, your swallow is going to be better. So timing of the drug should be given so that the max effect of the drug can be used to facilitate the oral and pharyngeal functions during your meals. And again, that Sinemet should be taken about 30 to 60 minutes before eating, because the amino acids in meats and dairy can impact that absorption. But if meds have to be discontinued for any reason, so say to evaluate your response to another medication, you may be more at risk for aspiration during that time, because all the muscles and things may not be working at optimum. So that was all the compensatory strategies that we can use. Then there's also what we call rehabilitative strategies. So again, these are sort of exercises and things that you can do to sort of strengthen the muscles required for swallowing. So one of them is range of motion exercises for your tongue, lips, and vocal cords. And this may involve stretching and holding different types of postures. A speech pathologist might be able to give you some exercises to try and do to sort of strengthen those aspects. LSVT, if you saw the speech presentation that I did, I talk about LSVT and speak out. But if you didn't, it's called the Lee-Silverman voice treatment, and it's a whole treatment protocol for helping improve speech. But they find that by doing the activities for that, it also helps improve vocal cord closure, to bring those vocal cords together tighter, which produce better protection for your airway. So in 2002, El Sharkawi et al. Found that it decreased the residue in the mouth and pharynx and decreased oral dysmobility. So doing that protocol, although it was working on speech, it actually helped decrease that amount of residue because everything was functioning much stronger. And the mouth tended to move more. So that would help with the oral phase of swallowing. There is also something called expiratory muscle strength training, and I will go into a little bit more information about that as well. That was studied by a speech pathologist called Christine Sapienza from the University of Florida. And they did a lot of research, especially with expiratory muscle strength training and Parkinson's disease. So if you're interested in that research and you put into Google expiratory muscle strength training and Parkinson's disease, you'll see all of the research over the last few years regarding that. Then there's also some swallowing exercises that might be done as well. And I'm going to tell you about a few of them that you can try as well. So expiratory muscle strength training, it's actually a spring-loaded pressure threshold device. So I actually have one. Disappeared for a moment, I'm back. And it looks like this. So it's a little device like this. It's got a spring in the middle of it. And what happens is you can tighten it and loosen it off. And when you try and blow on it, it has a valve that sort of releases. So when you blow into it and you blow it and go, it sort of releases. And what it actually does is strengthen the muscles needed for coughing. So it's the really, really deep abdominal muscles that it's used for, and it strengthens those to help have a stronger cough. Because when we were saying, when any food or fluid hits those vocal cords, it causes you to cough. But if your cough is weak, like a that kind of cough is not going to clear anything sitting on the vocal cords. You want a strong to try and clear anything from there. So what they found is that by using this type of device, it tended to help strengthen those muscles to improve the cough, to clear anything. And it started to decrease the risk of having aspiration. So they did use this in clinics with athletes and professional singers and actors. and with people with asthma, and it was to strengthen the muscles used for breathing. It's been used to treat speech and swallowing in Parkinson's disease, multiple systems atrophy, stroke, and Lance-Adams syndrome. The results of this research have actually been very good. They found that it reduced the hypophonia, so a little bit better loudness. But when I asked Christine Sapienza about it at a conference and said, you know, does that help with breathing, with respiratory support? And she said, it goes to the much more deep level of muscles. So not necessarily going to help with speech, but more going to help with that cough to clear things. But one of the bonuses was that many people found that when they did the exercises for this, they managed, because it's those muscles used for coughing, for bearing down, for lifting boxes and things, as well as for going to the bathroom, they found that they were able to poop better. So that was an added bonus, and said people were very pleased by that, because some of the medications can be very constipating, but with those stronger, deeper abdominal muscles, they had better success. So that's a bonus. Some improved intelligibility. Not really sure how that worked, but it might have just been from being able to have that better respiratory support. But the big thing was finding they had reduced aspiration and penetration of food into the airway, and that cough was strengthened. So it decreased their risk of aspiration, which was great. So the conclusions from their research was that it can be used to help treat swallowing in Parkinson's disease. It hasn't been used at the most severe stage of Parkinson's disease, though. That voluntary cough predicts penetration slash aspiration in people with Parkinson's disease. Voluntary cough competence is improved by EMST when the protocol is followed. It has physiologic and quality of life implications because it makes that much easier and decreases that risk of aspiration. They don't know what the durability of the results are yet. They don't know how long it lasts. If you follow the protocol for it, it's something like you practice 5 times a day, 5 days a week for 5 weeks or something like that. They don't know if after you're finished that protocol, how long it lasts for. Do you have to do some maintenance for it? Maybe continue to do it once a week or twice a week, something like that. So I think they're working on some of that. It's not a cure-all, but they are finding that it is definitely a powerful new tool. They need more replication of the research to make sure that it can be, that it has those lasting effects. And one of the studies from 2010 showed increased swallow safety and increased hyolaryngeal movement. So again, that's the larynx being able to come up and forward, that it actually helped to improve that as well. Because I think it sort of helps strengthen all the muscles in the neck too. So now if we, and I know people are gonna be like, where do you get this from? And I do have the website for you. It is in the internet resources. The one issue with it is somebody had asked me before whether Health Canada has approved it. And Health Canada, when I talked to the company about that, they said they haven't really, you know, Health Canada gets so many things that it takes a long time for things to be approved. And it's a company out of the US, so I don't believe they have sort of broached Health Canada about it. What's really important though is that they're, well, actually I'll get to that in a moment. You can get it. In the States, it's sort of considered a exercise equipment. They said it's akin to a treadmill, but that's what it said. It's exercise equipment. That being said, you have to be careful with using it because it is contraindicated for people who have high blood pressure or who have had heart issues, because anyone who is not supposed to bear down, that's what this helps doing. So any people who have heart issues, or blood pressure issues, you must check with your doctor first before just ordering this and deciding to do it. Really research it first and talk to your doctor, because it definitely is contraindicated for that. Some other exercises that I want to talk to you about. Oh, there you see my contraindications would be undiagnosed, untreated hypertension, cardiac issues, secondary to having to bear down for some exercises. So some other exercises, these are actually not just for people with Parkinson's disease. Natural aging will cause weakness and difficulty having that strength for swallowing. So these exercises are actually good for anyone who is aging or finding that they're having difficulty with swallowing. Even if you're not having difficulty with swallowing, it's like anything, being proactive and doing some exercises to maintain your strength and mobility is really important. This is no different. This helps strengthen the muscles for swallowing and increases their mobility to make sure everything is still moving the way it should. So I'm going to tell you a little bit about some of these. We have what we call the effortful swallow or the hard swallow, and it's exactly that. It's sort of feeling like you have a golf ball in your throat and trying to swallow that golf ball down. And what you do is you sort of tense all of the muscles in your neck as if you're trying to swallow that golf ball. So it's just, and swallowing down. So really making that effortful swallow to squeeze all of the muscles to get something down. Don't do it with food in your mouth unless it's actually been recommended to you as one of your compensatory strategies for swallowing. It's really best to just kind of practice it on its own. The Showa maneuver is where you put your tongue to the roof of your mouth like this and you swallow. So it's going to look like, and what it does is it sort of takes the tongue out of the equation a little bit and strengthens all of those muscles. The next one is called the towel tuck. And all you do is you roll up a towel, you put it under your neck, and you kind of look down and swallow. So again, it's just working on different muscle groupings. You can also do a combination where you do the towel tuck and the Showa maneuver and the hard swallow all at the same time. So you have your towel, put it under your chin, put your tongue to the roof of your mouth, and hard swallow while the towel is there. So again, it's all doing different types of muscle groups. Another really easy one is what we call hawk. So the k sound is made by your tongue moving backwards in your throat. Why this is important is because if you remember from that video that showed the disordered swallow where food and fluid sort of has all that residue, part of the reason for that is there's not enough air pressure, enough pressure from above that's pushing the food down into the esophagus. If you have the back of your tongue moving towards the back of the throat like this, you're getting better air pressure to move food and fluid down to the right spot. So how we get that tongue movement back is to produce sounds like k and g, because they are used, that's how the tongue moves to create that sound. So when you say things like hawk, 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 it moves the tongue base backwards. So this is very useful for improving that base of tongue movement. There's the shaker exercise that was named after a doctor who created this. And what it looks like is, do I have a picture of it here? Usually when I do this in person, you guys have all these handouts so you can see them. But how the shaker exercise looks is you're lying flat on a bed or on a couch or on the floor, even better. And you lift your neck up and you look at your toes and you hold that position for 30 seconds and then relax. It's kind of like a sit-up for your neck. You can also do it where you look to your toes and hold for 1 second and do that 30 times. And what that does is it starts to strengthen all of these muscles in your neck to be able to help improve that hyolaryngeal elevation and get that larynx moving up so that epiglottis can tip down. Now, for some people, that's difficult to do if you've got neck issues and things like that. We do have, there was a speech pathologist who, her and her husband, who was an engineer, created kind of a plexiglass device that you can use that does the same type of thing as lying down and doing the neck sit-up, like the shaker exercise, but sitting in your chair. So it looks like, mine is old. I'm sure she's redone the design more recently. Mine is quite a few years old, but kind of looks like this. It's sort of a piece of plexiglass, but what she does is you hold it here and then you get resistance by pushing down. So she created this. She's had some very good success with her own patients using it. I've had success with one of my clients who was having a lot of swallowing issues, and he was using it, and it did help maintain all the strength in his neck. And he'd been hospitalized a couple times for pneumonia from aspiration, and he went for at least a year without having to go back because he was doing some of the exercises and things, and he was using something like that. Whether that was the cause of him improving, I don't know, but it certainly seemed to help. Another swallowing exercise is what we call the Masako maneuver. And just like I said, moving the tongue base to the back of the throat helps increase air pressure. Trying to move that back pharynx forward also helps. So if they're doing this, they're creating better air pressure to try and force things down into the right tube, into the esophagus. So what the Masako maneuver does is actually takes the tongue out of the equation and forces the back wall to move forward. So how you do it is you actually kind of bite the tip of your tongue and swallow. So you keep your tongue out and not allowing it to move back. So it's, again, you just put your tongue between your teeth and swallow. And that helps move that back wall forward. So again, those are some exercises that you can use. What's the prescription for them? There was a presentation by Joe Rosenbeck, who is a speech-language pathologist also from the University of Florida, who has worked with Christine Sapienza, and he suggested that pick 3 of them a day and do each one 25 times. So 75 in total every day, and all that does is that really helps to strengthen all of the muscles used for swallowing. And again, not just for Parkinson's disease, it's for everyone as we age. So when is it time to see a speech pathologist for swallowing issues? Because of decreased awareness of swallowing issues, it is important to listen to the people close to you who know you and are starting to notice changes. Things like we talked about, losing weight, not enjoying eating, coughing, or having sort of, can hear a gurgly voice quality of something kind of sitting on those vocal cords. Things like that that you're starting to notice, those are sort of those signs and symptoms of a swallowing disorder. Once you see a speech-language pathologist, they can sort of monitor you and keep you in their sights and sort of help see how things change and help you give you compensatory strategies or rehabilitative strategies as you go. So the earlier the better, so that you can learn those strategies and do those exercises to use them throughout your life. So in Calgary, I don't know about Edmonton or other areas around Alberta, but in Calgary, we have an outpatient swallow clinic at the Peter Lougheed, and we also have one at the South Health Campus. So referrals are accepted from any healthcare professional, but a doctor needs to be aware because they often have to sign a requisition in case you're going to have a modified barium swallow or a FEES done. And the best way to access them is through your family doctor. If you go to your family doctor and you say, I'm worried that I have some swallowing issues, could you put a referral into the outpatient swallow clinic? I don't know if all doctors are aware of it or not. Often if I have a patient who I want to send there, I will write a letter to their doctor expressing what's going on, and I send them the documentation that needs to be signed and along with my letter, and then they send the referral off from their office. So the referrals are often, they're received and they're triaged. If it's urgent, the client's booked right away. If it's routine, that the person's doing okay, they're not getting sick, but they've noticed some issues, you're sent a questionnaire and an appointment is booked once the questionnaire is received. And sometimes people have to go direct to modified barium swallow. And so that's booked without a questionnaire because usually they have all the information required, like they have spoken to the doctor and the doctor has said it's emergent, or they've spoken to the speech pathologist and said that it's emergent, and so it gets taken care of. So who sees people with Parkinson's disease related swallowing issues as well? Beyond the outpatient, that's outpatient swallow clinic, they mainly will do an assessment and then recommendations. Home care, if you're already being followed by home care, they can sometimes give you a bedside assessment, maybe some treatment and consultation, and possibly also refer you on if you need a further assessment. Private speech-language pathologists choose someone who specializes in Parkinson's disease. You can find private practitioners on the ASAP website. That's actually for all of Alberta. So if you're looking for a private speech pathologist anywhere in Alberta, you can locate them there. So that's that for now. Internet resources, Parkinson Alberta Society. There's the email for the expiratory muscle strength training device. It's emst150.com. The device that I showed you for the shaker exercise sitting up is actually called the Dysphagia Flex device, and the woman's website is www.alternativespeech.com. She's got some of her research on there as well, with some case studies and stuff of what she's done with that device. In Calgary, Community Accessible Rehabilitation Services, they can also refer for, if you're already seeing them for speech or something like that, they can also help access the outpatient swallow clinic. And then our private speech language pathologists as well. So how are we doing for time? Good. We've got, it's only been 40 minutes. So hopefully we've got lots of time to answer questions that people have. Okay. All right, Emma, what can I do?
Yeah, so, well, one person was asking if you could show those two assistive devices again, just so we can get a closer look. Before that, do you mind just stopping the screen share so it shows up a bit better on our screen? Okay.
There we go. Ha!
Perfect.
There we go.
Yes, just so we can get a better look at them. Now it's a bit bigger. Yeah.
So this is the EMST device. It sort of has that opening there, and that's where you kind of blow through. The spring loading part is in here. It sort of has, you kind of can twist it to make it harder or easier. So when you actually use the device, you first start at where you kind of wind it down as far as you can until you can't break that seal. And then you have to off it a little bit until you can just release that seal. Then what happens is each week you kind of make it a little bit more challenging. So you do like a quarter turn to make it a bit tougher so that it continues to build up those muscles. So initially it's going to be very weak so that you can get it out, but then you make it a bit tougher. I can't remember if it's like once a week or something like that, but you kind of twist it. It's all in the protocol that comes with the device. It is best to kind of use it with a speech pathologist so they can follow you. I actually haven't had any clients that have used it, at least in the last few years, just because I haven't had clients who have needed it. But if it's something that people want to be proactive about, they certainly can look into it. The other one being that Fagiflex. Again, it's just a piece of plexiglass that the woman's husband sort of engineered to sort of be able to, you hold it at your chest and then the gray part goes under your chin. For those people who did watch the speech one as well, this woman, for doing LSVT and doing the ahs and the highs and lows, she actually does it while using this device as well, because she found that with the pressure, it helped close the vocal cords better too when she was doing the highs and the lows and the ahs. For those of you who don't have a clue what I'm talking about, if you go back and look at the speech presentation, I talk a little bit about LSVT and how that works. So she kind of does that as a combination. So she uses this for swallowing and speech, which kind of is kind of funky. It's very simple, but, and again, like I say, she may have changed things over the years. Like you can see on this, the padding is it's not sticking as well anymore. So she may have upped her design a little bit over the last little while, so.
Perfect, thank you. And so just to go back on that swallowing webinar, if anybody missed it and they were wanting to see it, it's up on our YouTube channel. So if you go to YouTube and search the Parkinson Association of Alberta, it should be one of the first few videos up there so you can watch it. Or if you're having difficulty, you can always call one of our offices and we can give you a hand. The other thing I wanted to mention was we mentioned some programs that were specific to Calgary, like the Speech and Swallowing Clinic or the CAR program. Those programs exist in other cities as well. So if you are wanting information about that and you're not sure where to start, I'd recommend calling the client service coordinator in your city and they'll be able to direct you in the right areas and give you more information. One of the other questions was about managing saliva, but I think that you covered that quite well. And then the other question, it was a question that I had actually. Someone mentioned a thickening formula, and I'm wondering if you would recommend that to help with swallowing.
So thickening is really dependent on the person. That's why no one should just kind of be like, oh, I should just get a thickened formula. They should go through a speech-language pathologist, have an assessment done. Reason being that if you remember on the video where I showed the amount of residue that builds up, the problem is if you have residue building up and you don't have a strong enough swallow, it actually causes more problems because you get too much buildup of the thickened fluid and then it falls over into the open airway. So it used to be traditionally that people have problems swallowing, they'd go to the hospital, nursing staff would immediately put them on pureed food and thickened fluids. And what they found is that can be actually detrimental to some people. In fact, sometimes it's safer for people to have the thinner water, even though they may cough every once in a while, than it would be for them to have a thickened beverage because becomes too thick, cakes up on those walls, and they don't have enough pressure to push it down. And it gets even harder because there's so much more in there to try and clear that. So definitely if people are finding, there may be certain consistencies that they'll find are easier. Like they may say, you know what, I don't do as well. I cough all the time on water, but I never cough when I make myself a smoothie. And it may be that the smoothie's consistency is thicker enough that it slows it down for them for swallowing, but they can still manage it in their throat. There's like different levels of thickness as well. So it's best that if people are thinking, maybe I would do better on things that are a bit thicker, is to have an assessment and to make sure that it's the right consistency for them, really.
Right, okay. Good. And then I think it's not really a question, but I thought I'd pass it along. Someone just wanted to know that they found the session very informative. They had some previous knowledge on swallowing, but still found it informative.
Oh, great. Well, thank you. And yeah, if there are questions and stuff and you have questions later and you forward them to Emma, she can always forward them to me and I'm happy to answer them.
Yeah, or if anybody wants those handouts, just let me know and then we can pass that along.
Certainly forward that to you.
Yeah, but I think that's it for questions. If we'll leave it a minute maybe and see if anybody else has some. But thank you so much for joining us today and sharing your knowledge on Parkinson's and speech last week and this week on swallowing. It was great to get that information.
Awesome.
And
sorry for all the technical difficulties.
It happens. It's okay. And thank you to everyone who joined us live and shared your questions. We do have another webinar next week. It's Wednesday, August 26th, and it's about Parkinson's and nutrition, and that one's at 10 a.m. So if you're wanting to join, you can register online at the parkinsonassociation.ca. And thank you again, Jenny. It was great to have you.
Thanks, Emma. Good to see you.
Okay, bye.
Bye-bye.